Hi, good morning and good afternoon or good evening, everyone. Welcome to the second episode of Nail It with Nadira, the Radcliffe edition. My name is Nadira Hamid. I'm an interventional echocardiographer from Minneapolis Heart Institute, and today I am delighted to be your moderator again with an esteemed panelist and faculty that I've gathered. And today, the session that I'll be talking about, or we all will be discussing about, is success in SESAME, which is one of the novel transcatheter electrosurgery modification technique really pioneered by the best of the best, and they are all on this panel. Like I said, this Nail It with Nadira is a very case-based with a little didactic, and we want to show the real world, the practical aspects of these complex procedures, when to consider it, how to consider it, plan it in terms of imaging, and perform it safely in terms of patient selection. And who else better than imaging as well to understand this procedure for patient selection and then the follow-up process of it as well. In addition to that, really honored to have a balanced perspective from my surgical colleague from University of Michigan to understand about surgical myomectomy as well. Just a few quick housekeeping notes. This session is being recorded and will be available on Transcatheter Academy. Please send all your questions at any time during this webinar with the Q&A. They will come straight to me directly, and we will do our ultimate best to really answer these questions during the talks and session or at the end of this session. So please don't wait towards the end of the session for the questions. And without further ado, I'm very pleased to introduce my well-esteemed faculty. So first and foremost, we have Dr. Jafar Khan from St. Francis Hospital Heart Center from Long Island. First, he will take us off as an introduction to Open Sesame. What is the evidence and why we should do it? Outlining the concept, the technique, and the key evidence that is up to date. Secondly, was my colleague, my longtime colleague and mentor, Dr. Omar Khalik, also from San Francisco as well, who has pioneered the pre-procedural imaging and is a key multimodality imager in the world, really covering the key essentials of the SESAME procedure, what to look out for, not only pre-procedure, but also during the procedure as well, and the follow-up imaging of these complex patients. Thirdly, we have really honored to have Dr. Ignacio Amat Santos from all the way from Spain. Thank you so much for joining us. Really, what is the clinical best practices, right? How to select the patient? What is the key tips and tricks of these procedure, of the SESAME procedure, and how, most importantly, how to avoid complications? And last but not least, really honored to have a well-renowned surgeon all the way from University of Michigan, Dr. Francis Pagani, who will present to us why surgical myomectomy is still the best preferred option. And really comparing and giving us a balanced approach and perspective versus the transcatheter approaches as well. So my aim really today is to bring forward not only this SESAME procedure, how to put it in your clinical practice and really the patient selection and really discuss in your valve team for these complex patients as well. And so without further ado, let's open the SESAME for the next hour, and we'll start off with Dr. Jafar Khan.
Thank you so much, Nadira, and congratulations on putting together such a fantastic program. My job today is just to give you an introduction to SESAME and talk through the evidence that we have to date. We wouldn't be here without the effort of my fellows and pioneers in electrosurgery. I just want to shout out Adam, Vasilis, Jamie, Robert, and Toby, just for bringing these procedures to our patients that need them. The topic we're going to talk about, SESAME, essentially augments the LVOT. And we need LVOT augmentation for two main buckets of patients. The first is those with hypertrophic cardiomyopathy. This is the commonest inherited cardiac conditions, typically diagnosed in patients in their 40s and 50s. And the current options all have limitations. We know we recently have cardiac myosin inhibitors. They're very costly, about $100,000 a year for the patient, a pill a day for life. And we know that it's not as effective as surgical myectomy. Alcohol septal ablation has been around since the early 90s. but there's a 15% anatomical miss and a 15% pacemaker rate, making this not an ideal first-line therapy. And surgery is excellent with a couple of caveats. It's very good if you're young as the patient, the outcomes worsen with age. And it's very good if you're at a center that does them all the time. And we know that the vast majority of centers, especially in the United States, are very low volume centers doing low single digits, and the outcomes there are not great. So the next bucket of patients that require LVOT augmentations are those requiring transcatheter mitral valve replacement. We know that 90% of patients screen fail in clinical trials in the United States, and that's a huge number. And one of the main reasons for screen failure is fear of LVOT obstruction. Septal reduction is a nice adjunctive treatment for these patients because it's device agnostic. Other procedures like Lampoon rely on valve and frame design, whereas augmenting the septum can be done with any device you implant in. So let me introduce you to the concept of SESAME. These, you have this equipment on your shelf in the cath lab today, so no specialist equipment needed. You put two coronary guiding catheters, one up against the septum, and through that you poke a stiff wire, we usually use an Astato 40 wire, through the septum and navigate that through the heart backed up with a microcatheter, typically a fine cross or something similar. We snare that in the left ventricle, form that loop, the flying V, which many of you will be familiar with if you're familiar with electrosurgical techniques, and cut the muscle. And this is a myotomy, so we just get a single cut. And what you will notice is that circumferential fibers in the septum pull this septum apart, creating a channel for blood to flow in the LVOT. So we augment the LVOT without actually having to remove any heart muscle. This is not a new concept. The first surgery in 1961, done by investigators from the NIH, Morrow and Brockenborough, was a myotomy. And the surgical literature from the 60s and 70s is not great, but what we do have shows that this was indeed effective. And you can see there's a small series in 1974 showing reduction in gradients. Eventually, this was superseded by myectomy with better results, but I think the proof of principle is certainly there that myotomy can work. Taking the proof of principle further, this has been performed now in patients. This is a fluoroscopy of the first patient that received this. You can see that actually a transseptal ICE catheter is positioned down in the left ventricle. We don't use that anymore, but the two catheters you see with the wire loop in the left ventricle, this is during electrification. And on the CT on the right-hand side, the top panel shows the baseline imaging with a very thick, bulky septum for this patient. And in the same phase, 30 days afterwards, you can see that the LVOT area is vastly improved. So what's the evidence so far? I'm going to talk about three studies. The first is this retrospective study of the first 76 patients in which SESAME was performed. So this includes the first in human data. This was done at Emory. 11 patients who had hypertrophic cardiomyopathy and 65 pre-valve replacement. And these were split into patients who had an LVOT gradient and those that didn't. And as you can imagine from this first in human cohort, they're all high surgical risk. And they're women, mostly female, and in their 70s. So technical success in the first in human cohort was 100%, defined as successful traversal and laceration of myocardium. Hemodynamic success, defined as a 50% reduction in LVOT gradient or to less than 30 at rest or less than 50 provoked, was seen in 70% of patients and 82% of patients with HOCA. ICU stay 1 day, hospital stay 4.5 days. Here are the LVOT gradients, so split into HOCM and split into valvular disease with a gradient. And you can see resting and provoked gradients come down in both groups significantly. Then when you look at LVOT area, and this is key for the pre-TMVR group, the key thing is the middle row here, neo-LVOT area at baseline, which is around 65 square millimeters, is augmented by about 150 square millimeters. And this is pretty consistent with what we see even today clinically, getting the majority of patients eligible for TMVR. Here's just a representation of what happens to septal thickness before and after SESAME. And here are the complications. So first, we look at the overall cohort of 76 patients and just run down the line. Complications are in the low single digits percentage-wise. So that's encouraging. However, especially in this early cohort, the key complications here, death in 2.6%, that's okay, but new VSDs and ventricular free wall ruptures, about 4% each. So that was a early concerning complication. And I think in Omar's talk specifically, we will understand how imaging is key to avoiding these complications. And our imaging protocols have got significantly better since this. Just to highlight, in the HOCM population, apart from one groin bleed, there was no complications. These generally are thicker septum, less frail patients than many of these patients that present with MAC and pre-TMVR. The second study was done looking at the University of Washington experience in their first 54 patients, and pretty similar results. You see that in the pre-TMVR population in the bottom left, the neo-LVOT was augmented again by 150, and quite good results here for the gradient population in HOCM. Low numbers, just 6 for the HOCM population, but the resting and provoked gradients reduced substantially. And this is just a nice curve showing that there was a substantial learning curve early in the experience. Complications, as you would expect, racked up, but later in the experience, these complications were very acceptable. Finally, the final paper I want to show is SESAME for subaortic membrane. Here's a representative patient with a subaortic membrane on echo and CT in the top row, and the result afterwards in the bottom row. There were 0 complications in this small patient cohort. The success in all, and you can see really nice representation of NYHA classification at baseline and then at 30 days for these patients. So I'd like to conclude there, saying that SESAME is a novel procedure. There is a learning curve. There is a surgical predicate. And it is promising because it is a one-and-done procedure, unlike a sort of a lifetime with expensive medications. And it's certainly evolving to be a safe and effective technique. The final thing I'd like to say is note about training. At the moment, the best way to start this procedure is reverse proctoring. So go to a site that is very familiar and does these procedures with both your interventionalists and your interventional imager, and watch some cases before doing this at home. Thank you very much.
Thank you very much, Jafar. That was a great introduction to SESAME with the key evidence. Just a quick question before I move to Dr. Khalid's talk. And you mentioned about the learning curve and the advice to really get into, reverse proctoring. How many procedures do you think would someone be comfortable, right, with your experience? Not to say to do it every week, but, for key cases, for someone to be competent enough in these cases, how many cases do you think will someone should be doing to be comfortable in the SESAME procedure?
I think you need to have a regular cadence, and so I think around 2 a month is a reasonable reasonable caseload, even one a month. It's just the frequency of doing it. If you haven't done any procedure for several months, it can be difficult. The second thing to say is I think there's no substitute for going in person to a site that does it, to get trained and watch a few cases, because at the moment there is very limited ability for us to go out and proctor.
And one of the questions is how much time realistically in the real world for centers just starting in terms of blocking the cath lab for SESAME case for setup, procedure, recovery, and intraprocedural imaging?
I think realistically, when you're starting, you need to get a 3-hour time block. I think that's true. I wonder if others on the panel would agree. And then once you have a good cadence, that can certainly come down. A lot of it's to do with the setup, getting the room right. If you have biplane, how to get transthoracic and TE in all set up. Many of it's that rather than the actual time in the procedure.
And finally, before the next talk is, you mentioned about TMVR trials. Do you think that having this procedure in these trials, because as you know, the rejection rates, even us, a lot of the time is the LVOT, and do you think these kind of procedures should be incorporated in the trials for improve, enhance enrollment of these trials?
So the advantage of this is you can do anything to the patient before they're enrolled in the trial, right? So this is pre-enrollment, and we're actually sent cases that go on to have their TMVR trial elsewhere in the country, but we'll do their SESAME first and send them back to their home hospital, which will then enroll them in the TMVR trial. So you can do a septal reduction before enrollment. It's actually not captured in the trial itself.
Yeah. Thank you so much. And next we'll have Dr. Omar Khalik, a multimodality imager, really a true pioneer in multimodality and also in the SESAME procedures. So take us through what are the key essential imaging that is needed for patient selection and most importantly, during the procedure, and also like what Jafar was saying, to avoid these complications of the VSD and the ventricular free wall rupture. So, Dr. Khalik, thank you.
Thank you very much. Excited to be here and to show some of our workflows for this technology. So I'll start with the CT pre-planning, then the intraprocedural echo, followed by a case which will demonstrate some of the principles. So number one with CT is always the acquisition. So the simplest way to think about this, I think, is to work off of your baseline TAVR or TMVR protocol. What we like to see, because we need to see the interventricular septum, is to have some degree of right-sided opacification. It doesn't have to be a lot, but at least to delineate the thickness. So we want to adjust the contrast bolus length to add some right-sided opacification. And the easiest way to do this, and what we typically do, is to add an extra 5 seconds of contrast into the bolus to trail behind in the right side. And the contrast saline mixture is beneficial because you reduce your contrast volume, and it's also a smoother bolus, avoiding some of the streak artifacts you get with pure contrast on the right side. So the general plan, when you've identified a patient for potential SESAME, is we look at the septal thickness. You see the red arrows. We plan to cut about half of that. And that's how we plan the procedure. One key, which you see just below the title, is to be aware of the RV trabeculation. So you see my red arrow fall short of the right side. And that's because there's some blood pool within those spaces in the RV trabeculation side of the interventricular septum. So we don't want to overestimate the thickness that we have to work with. So the yellow line, which is the direction of our cut, we're drawing approximately at that halfway point, and through that septal bulge or the area that's going to be cut. So in this particular case, the red arrows measure 16 millimeters, so we're aiming about 8 millimeters depth. And others can comment, but our practice has been to leave at least 5 to 6 millimeters on the RV side of the septum, and you exclude trabeculations in that. And then for the yellow arrow, you see 21 millimeters in this particular case from entry to exit point. And that's something we can also correlate to the intraprocedural echo to make sure we're doing what we aim to do. So we're cutting that through the red arrow at approximately half the depth of it. Another thing is to plan your fluoro views, which I think is very, very helpful. We use a biplane lab, but Jaffer has told me this can be done in single plane as well. So we see on the left CT simulated RAO caudal view, right? So that's like our 3-chamber view from echo with a center line, which you can put through the LVOT or through the septum. So you can have a correlation for within the lab that you're going in the right direction. And then on the right is kind of a modified short axis view, orthogonal to the left-hand view. And this will usually be an LAO. And then this helps us to make sure we're going to the center of our target, which is typically in the middle of the LVOT axis or the septum. Another thing to just be aware of, so in this case, you see the yellow dashed line, which is through the center of the right coronary cusp and goes in a straight trajectory. However, in this particular case, where the dots are is where the septum travels. So sometimes the septum can travel not in the midline, but a little bit to the non-side or the left side. So you just want to be aware of this when you go into your case and make sure you're tracking things appropriately. And of course, you recheck on the intraprocedural echo where you can also see the septal direction. So moving on to intraprocedural echo, we have our TE and our TTE. Many of the images I'm going to show are based on this multi-center publication on echo imaging for SESAME, which has been accepted and is in press for JACE journal. So step 1 is finding the entry point. We want to position ourselves appropriately for the retrograde access to the basal septum. So as I mentioned, septal trajectory may be shifted left or right from the center of the right coronary cusp. So we saw that on the CT, and we'll also see it on the TE. So you want to keep that in mind as we track our wire going through the myocardium. This is an example of the fluoroscopic guidance. So again, to reiterate, it's typically an RAO caudal for the 3-chamber and an LAO cranial, which is then transmitted into the cath lab. A key message is to use all of your tools. So we use 2D, 3D. MPR is very important here, as it is with many interventions. And also transthoracic echo is a key part of our procedures. And you have to see that entire wire path through the myocardium. So you see on the upper left-hand image, which we can track on 2D TEE. 3D is also helpful in panel B. The next panel shows MPR, which can help you because your wire's not usually going in a straight trajectory. So you need to be able to track it all the way through. And then on the lower right, you see transthoracic images, which we use routinely in our workflow as the direction of the wire is perpendicular to the incination beam. So we often get very, very good images. And if there's any questions, we always use this to confirm our wire depth, trajectory, and exit point. So here are some examples of incorrect trajectories. We talked about avoiding complications. On the left, you can see the wire. It's too deep, right? It's near the RVOT, which you don't want because you can get a VSD. B, too shallow. So that one is safe, but we're not getting much of the septum, so it won't be a successful procedure potentially. And then C, you've already gone into the RV cavity, so that's important to recognize early before you do the actual cut. I spoke before about the reentry point. So we're going through the myocardium and exiting into the LV. So we need to clearly visualize that. So use whatever methods you have, but it has to be very, very clear. And we've seen cases where on the fluoroscopy, it looks like it's exiting, but it's actually going in a different direction. So very, very key to use all those tools that I mentioned, including 2D, 3D, MPR, transthoracic echo, to make sure you see the wire in the LV beyond the exit point. I'm going to go through a quick case which will demonstrate some of this. 80-year-old female referred for severe MAC with MR and MS, no surgical option, planned for TMVR. So this is a case and a good example of probably something that I would have been very afraid of and probably wouldn't have been possible without the SESAME. So here's the baseline imaging. So you see severe MAC, MS, and significant MR as well, mixed disease. Here's the baseline CT. Neo-LVOT area is 42, so very, very low, with a modeling of 29 S3 valve for valve and MAC. Basal septum thickness, I like to measure this in diastole and systole to get a range. So here it's between 1.7 to 2.3. So our plan was to have staged procedures to increase neo-LVOT size before the TMVR. Alcohol ablation was mentioned by Jaffer. So this is one of our early cases, but actually most of our referrings and operators have moved away from this after we've had very successful results with SESAME. But here is the case for this one. Basal septum injected with contrast, so we know we have the right zone. So here's the CT about 1 month later. So we did get some decrease in septal thickness, although not tremendous. So about 25 in systole to 20 millimeters after the remodeling. Here's the post-ablation CT neo-LVOT analysis. So we did get, actually, you see on each side of the LVOT a good amount of increase, 42 to 148. But we felt there was more to do to really make this the eventual TMVR safe. So of course we planned on SESAME. Here's an image I like to show of Jaffer because he really enjoys this. So here's the planning, as I mentioned. So here's the yellow arrow again, right, cutting through about half the thickness. So we had 20 millimeters, as I mentioned. Here's 10 millimeters depth we're planning for, and then 22 millimeters of length going from just below the aortic prosthesis into the myocardium, and then exiting just beyond the bulge. Here are CT-based fluoro views for this one, as I showed before. So an areocaudal view lining up our LVOT, and then kind of a short axis view, which is an LAO view on the right, coming straight down the middle. And here are the actual views that were planned transmitted into the case. So they were essentially the same views. You see the system starting to come in. Here's your wire in the septum, right? So very clearly seen down the midline. And you can see on the right-hand image, there's a little bit of shift towards, the left side versus the non. It's not directly midline. In this particular case, this was an early one, but I think also one of our most difficult because we had severe MAC, aortic prosthesis, and there was a lot of shadowing. So we actually used many different echocardiographic tools to ensure our depth. And you can see actually on the lower right that on transthoracic echo, the trajectory and depth was very well seen. We were a little gun shy here, so we hit about 7 millimeters instead of 10, but we thought that could be adequate. Here's the snaring and tightening of the loop. So again, on the planned views. And here's the cut. Boom. So in the procedure, here's an example of the post-procedure imaging. So you usually get this V-shaped or slit-like cut, but that opens up over time in the follow-up. So we thought this was a pretty good one. Here's the CT 1 month post-SESAME. So we got most of the bulge. We fell slightly short of the wire trajectory, but our depth was actually between 7 to 9 with a planned depth of 10. So we came close to our target. And we got up to about 190 on the neo-LVOT area from the original value, which was about 48 at the beginning. So as Jaffer says, nobody ever suffered from having too much LVOT area. So we plan for the TMVR, but also with the Lampoon procedure, which probably everyone's familiar with at this point. Here's the guidance from the intraprocedural biplane TE, where we see the snare loop coming through the anterior leaflet. Here's the loop. Here's the laceration, confirmed with the color Doppler coming straight through the leaflet. Here's the laceration at the midline of A2. And here is the result, very, very nice result, a very trivial PVL you see on the right-hand image at about 3 o'clock. And a very acceptable LVOT peak velocity. It's the hyperdynamic LV, so 2.8 meters per second. So summary here, we use SESAME as part of a cascade to really provide more new LVOT area, which with a case that I think otherwise would not have been doable. Thank you very much.
Thank you very much, Omar. I mean, that is such an fantastic illustrations of the key essentials of imaging. I mean, pre and intraprocedural, and I absolutely love the case because you highlight the important thing about increasing the neo LVOT, like what Jafar likes, right? He wants more neo LVOT is not an issue, and using the multiple tools to really help the patient with a TMVR option. So not to just one option like alcohol septal ablation, which is not enough, and to think more. And so really that really opens up the box. And two key questions by the audience, Omar, before I move to Ignacio's talk. Both are similar as to what is in summary, right? What is the exact or key measurements of view or clinical or anatomical features that when you review a CT and echo that you will schedule a patient for SESAME next week with proctoring with Jafar?
Yeah, so I mean, others can comment, but my personal thought and the other advantage of SESAME is that you don't need a ton of septal thickness, right? Like with alcohol ablation, since the result is unpredictable and you're very worried about VSDs, you kind of shy away from low septal thicknesses. But here, even with, a 1.2 septal thickness, right, you can modulate your cut in order to be safe but deep enough to get some results out of it. So I think septal thickness wise, there are fewer limitations than what you would have with alcohol ablation, for example. But other than that, I don't think there's a lot of limitation. I mean, obviously you're not doing a super thin septum that you don't think is contributing to the reduction in the neo LVOT area. But there aren't typically a lot of red flags. But the other thing that can come up, which you can see on the procedure or imaging side, which is part of the reason we've shied away from alcohol ablation, is that if you see a lot of scarring at the basal septum, which can occur with alcohol ablation, it can make the entry point of the SESAME tougher. So otherwise, imaging, I mean, there's really not many contraindications, I would say.
And do you do cardiac MRI for these patients to appreciate that fibrosis or, calcification at that basal septum to see whether alcohol?
We've done it on a limited basis. Yeah, we've done it on a limited basis, especially with the HCM patients, because to evaluate the post results along with the echo in terms of the SAMs, the scarring, and the LVOT obstruction. But for the most part, we haven't routinely done MRIs because it's a mixed population. So we have some TMVR MAC cases like the one I've shown, and HCM and some membrane cases.
And Jafar, do you have any comments?
No, I agree. I think very few contraindications to doing it. We haven't done a mechanical aortic valve, but I know they have in you can do it in a transseptal approach. But I agree with Omar.
Great. And Omar and Jafar, maybe you can answer this question from a patient's perspective. What do you think the risk and recovery after SESAME comparing to alcohol septal ablation?
So alcohol septal ablation, we keep them on a monitor for 24 hours because of the risk of late heart block. In SESAME, we don't do that. If you don't see conduction disturbances in the case, they're unlikely to develop it down the road. So we put them in a monitored bed, but they go home the next day.
Okay. And so without further ado, really a true honor to introduce my third speaker, Dr. Ignacio, all the way from Spain, who take us through the practical aspects of SESAME and best practices as well. Ignacio, thank you.
Thank you very much. I just don't see yet my presentation on the slides, but I will use this time just to thank for having me and to say that it's a great pleasure to be among such esteemed colleagues. And I hope all the attendees find this really useful and use the opportunity to make as many questions as possible, because you have people who are really super experts in this new and expanding technique. So now I can see my presentation. This is more or less the index I will follow for my slide. So first, let's understand what's the problem to need this technique, the risk of LVOT obstruction. So we know that involving valve and valving ring is not so common to have this risk. It might happen in around 5% of the patients, but involving MAC is much more common. Up to 40% of the patients have a risk of LVOT obstruction. And what we know for sure is that when there is obstruction, that's an independent predictor of mortality. We also know, as we have discussed before, that there are other techniques as lampoon or leaflet modification and alcohol septal ablation that can reduce but not eliminate the risk of LVOT obstruction. And we can, like that, reduce the mortality, but again, not eliminate, especially in valving MAC cases, and more in native valves that are treated with dedicated devices, which is the new indication. When we need to do something, well, the classic indication for lampoon or Batman leaflet modification was neo LVOT below 150 millimeters square. We will discuss this later. And to do that, we need to have a long enough anterior mitral leaflet, which can be a limitation for these techniques. I want to show now one typical case. This is a not very calcified leaflets. We can clearly see the calcification of the mitral annulus. We are doing lampoon, which cut very clean, and then we can cross easily the valve with our balloon expandable device. We have a clear landmark, also a TAVI as a reference, and we can easily implant the valve. So this is an easy lampoon. And in the next slide, we can see how we do Batman, normally in more calcified anatomies, so usually higher risk. And what we typically do is that we inflate the balloon, have already a wire in parallel, and we use it as a body balloon to cross. You can understand that with these two techniques, especially Batman, the risk of hemodynamic compromise is relatively high in some patients. So if we have that, why do we need SESAME? Well, SESAME is a technique that, without running the risk of this hemodynamic compromise, can limit the LVOT obstruction in candidates to orthotopic mitral valves. Instead of treating the leaflet as lampoon or Barman, or treating the septum as the septal ablation, but in an unpredictable way and causing an infarction, we can use this alternative, which is a control modification, very predictable and with immediate effect, and also something that we can do in a prior procedure. So reevaluate with CT and then take the decision what we are going to do, if just implant the valve or add also a leaflet modification. The idea is that as mitral technologies are expanding, we also want to expand the patients that are candidates to these therapies. So we will add this alternative, the SESAME, in patients with small LV cavities, with a clear basal septal hypertrophy and the small LVOTs. We know we can do it with an immediate effect, so we will know if it worked or no, and also with a reduced risk of conduction disturbances if we compare with septal ablation. We know also that it's not active on the leaflet, but it can be complementary to that. So lampoon treats the leaflet, SESAME the ventricle, as was previously said. And I find it particularly useful in valving MAC, which is a relatively uncommon indication, but also to expand the candidates to M3, CardioValve, Intrepid, and the growing range of orthotopic technologies that we are having now. In this case, we potentially could have used SESAME. It's a failed lampoon case. And why is it failed? Well, when we do these leaflet modifications techniques, often we want to have the TAVI ready, the valve ready to be implanted. If we are using a SAPIEN device, this means that once it's inside the anatomical structures, we cannot remove it. So in this patient, we wanted to have the valve there. This means we have the Safari wire. And look what's happening. We have the Safari in the middle of the flying V. So that was a rookie mistake. Maybe we could have avoided it, but it's something that potentially could happen. And anyhow, at this point, it's difficult to correct because the valve is already in place. So of course, lampoon failed. We have to transform into Batman, and we were able to implant, but still, despite that, we have a high gradient. So the patient was relatively unstable. We have to balloon the LVOT. And we have to do coiling of the septal branch because the center where I was proctoring didn't have alcohol at that point. And luckily, we could solve the situation. But what if we have chosen SESAME? We would have avoided all this. And also, we could have avoided the potential consequences, which are that the valve had eccentric expansion. The LVOT was 156 millimeters square, which is not the best one. So we are compromising somehow the durability. Despite we saved the patient, but maybe SESAME could have been a better alternative and simpler. This is another scenario where SESAME can offer better options because look how calcified is the free edge of the anterior mitral leaflet. Anything we want to do here will be very high risk on the leaflet. And instead, a SESAME can be a very good alternative because the anatomy is favorable. These are the projections to prepare the trajectory and the result. And this is a classical case, as classic as the first TAVI case that we have seen already published. So where does SESAME fit? Well, it mimics a surgical myectomy, and we will learn more later on this. But on the contrary, as alcohol ablation, it does not cause any infarction. What are the indications? Is TMVR, but also hypertrophic cardiomyopathy. We have already discussed this scenario of a small neo LVOT, and this is the situation in hypertrophic cardiomyopathy. In this particular scenario, in obstructive hypertrophy, the problem is the septal hypertrophy, but also the systolic anterior motion of the leaflet. And the current options is the surgery, which is gold standard, but requires a surgeon who is expert on this technique, and alcohol septal ablation with the limitations that we already commented. We will consider SESAME in patients that remain symptomatic and with high gradient, but also that have an adequate anatomy with septal basal hypertrophy. And to take the decision on if we are doing SESAME or not, first for TMVR, we need to see that there is small LVOT. This is a case where we find under 100 neo LVOT. But only this calculation is sometimes not enough. For example, in this case, we are simulating the ideal position of the valve, and we see the neo LVOT. And when we reach the position where we could have the valve with the best result, the neo LVOT is 180. So maybe we don't need any modification of the LVOT, but if we do some fluid dynamic simulation, we can see that actually the acceleration, the peak acceleration, is related to more than 50 millimeters of mercury of gradient. So we need to learn more on how to estimate the risk of neo-LVOT obstruction. And for the protocol in our center for hypertrophic cardiomyopathy is first, if we have a patient with gradient and symptoms, we will consider all the medical armamentarium, beta blockers, mevacantem. But if despite that the patient is still symptomatic and with more than 30 at rest or 50 millimeters of mercury with exercise, we will consider the gold standard surgical myectomy. But if it's high risk, we will go directly for SESAME. And now the best practices for these techniques. First, the patient selection. We have seen a nice presentation on the imaging. We need enough septal thickness, enough LV cavity, but also if we have less than 15 millimeters in the septum or the trajectory is not adequate for that patient, especially if there are very close papillary or chordal muscles, then we might need to exclude the patient. It's very uncommon, to be honest. And then we need to do a good planning with imaging. Fusion with CT or simulation of the projections is very useful to predict the trajectory, and I will show it now. So here we have the case where we position the point of entry in the septum, a midpoint now in the septum as well, and the point of exit into the cavity. And with that simulation, we can measure the length that we are gonna have and the depth, which in this case is very limited. So probably it's a case that we have to discuss if we really want to do it or not. But then with this, we can do the simulation and find two projections that we will use in the biplane or in a single plane system. So this is one of the projections, and now we find the other one where it's central according to the mitral device. And with these two projections, we can perform the intervention. The specific best practices for hypertrophic cardiomyopathy. The target is not just the septum. We have to target for the basal hypertrophy system and trying to go through the SAM contact zone. Even if the septum is very thick, we should avoid going too deep because that can progress into a late ventricular septal defect and also increase the rate of conduction system injury. And Jafar before mentioned it, maybe we have to consider redo, and it's better to be more conservative, and if there is still some gradient in the follow-up, repeat the procedure. Now let's see the step by step very quickly. First, we need to identify the target. So this is a case where we simulate our valve. It's a valve in MAC case. We see that, again, it's around 100, the new LVOT, so there is clear indication. We mark the point of entry in the septum, mid portion, and point of exit. Then we simulate the projections of implantation. We measure that we have enough depth and enough septum. And these are the two projections that we will use during fluoroscopy. The next step is crossing. So not typically we position a hockey stick catheter within a deflectable sheath. We advance by torquing an astato wire. We can also use Gaia third, which can be better oriented. Then we use a coiled microcatheter to torque through the septum. This is only the fluoroscopy, and now we are snaring the wire. But in the next one, we have to check, and this was very much detailed before, that we have enough depth also by echo, and we can gently pull the system to see that there is no new mitral regurgitation, which will reflect that we are trapping some chordae or we are interacting with the mitral apparatus. Finally, we do the energy delivery. We have to keep very little exposed the wire and try not to pull too far away, especially if there is a native aortic valve, because we could potentially damage it. And finally, we need to check that the LVOT is large enough with a good gradient as well. So my take-home message now is that SESAME is a controlled, predictable, septal kind of myotomy that can be very useful both to prevent LVOT obstruction in TMVR and to treat this obstruction in patients with obstructive hypertrophic cardiomyopathy. Thank you very much.
Thank you very much, Ignacio. That was excellent. Step by step, really practical aspects to SESAME. One question before I move to Dr. Pagani, and we have a bunch of questions which we will address at the end of Dr. Pagani's talk. But one question is, have you changed your practice after that clinical case of yours that you presented, where you would do SESAME first before a lampoon or Batman?
Yeah, absolutely. Before I was using what I had, and that's the only thing we had. We were exploring a lot the Batman technique because we found it simpler. We reduced the number of steps, but sometimes crossing is difficult, and the minutes you use to dilate more the leaflet are very unstable for the patient. With SESAME, we never have that kind of instability. So if SESAME is feasible, that's my first step in most of the patients now, even if it's a good case for lampoon, because we still can do the lampoon during the index procedure.
Right. And what are your thoughts, Jafar? Have you changed that practice too now?
Unless the new LVOT is very large, there's, sort of over 250, we will do a staged procedure. Particularly if the patients have severe MAC, I think it has several benefits. They get better after the SESAME, and then usually even better after the TMVR. So we typically do a two-step procedure for patients with MAC wanting TMVR.
Thank you. And to complete the whole picture after transcatheter, let's go to our surgical colleague, Dr. Pagani, all the way from University of Michigan. I'm sure you had all the thoughts of transcatheter and seeing all these complex cases, and your perspective as to why surgical myomectomy may be the first choice. I know these are complex, high-risk patients, are not surgical candidates, but take us through the surgical myomectomy. Thank you so much, Dr. Pagani, for joining us.
Thank you, Nadira, and appreciate the invitation today. I see my role a little bit as a protagonist, but was quite impressed by the skill of the interventionalists and the quality of the imaging that really reinforces the technique. So my job today is really to emphasize why we think that surgical myectomy remains the gold standard for treatment in hypertrophic cardiomyopathy. And I'm really going to focus on hypertrophic cardiomyopathy as a disease pathology. One is we really should reframe the issue as not a disease of the septum alone, but this is really a disease incorporating many abnormal components of the subvalvular apparatus, the mitral valve, and also leaflets of the mitral valve that are markedly abnormal, frequently in patients with hypertrophic cardiomyopathy. And so this is really a disease of the ventricle and not simply the septum. And when you look at, the mitral valve is not a secondary, but actually a primary component of the pathology. We see leaflet elongation in about 30% of patients with hypertrophic cardiomyopathy. And there's frequently abnormal secondary chords that restrict posterior movement of the anterior leaflet of the mitral valve. And all these issues can be easily addressed with surgery. We also see abnormal papillary muscle formations. There's apical displacement of the papillary muscles, and also there may be insertion of the papillary muscle directly into the mitral valve leaflet. Again, emphasizing that hypertrophic cardiomyopathy is not simply a disease of the septum. And really what the recent guideline statements emphasize this point, where they say for patients in whom invasive septal reduction therapy is being contemplated, close examination of the mitral valve is required to determine the optimal invasive approach and the potential need for concomitant mitral valve intervention. So again, the guidelines highlight the emphasis of the mitral valve in the disease process. Our treatment landscape now includes septal myectomy, alcohol septal ablation, and emerging now SESAME. But I'd like to really emphasize 2 points. One, these decisions for these invasive therapies should be made in the context of a heart team support structure so that there is collaboration amongst the different recommendations for procedures for specific patients. And one of the criticisms of septal myectomy, it's restricted to really centers with a lot of experience. But when you looked at the presentations today, what you see are people or interventionalists and imaging cardiologists who are very skilled at the entire landscape of structural heart problems and transcatheter techniques. So I would argue that SESAME also requires advanced skill set that's seen in fewer centers. The other important aspect of septal myectomy is that we have greater now than 50 years of surgical experience. And it was first established, as previously mentioned, in the 1960s. But the operation that is done today is not the operation that we did 50 years ago. And I'll highlight that in a few other slides. We have thousands of cases of from high volume excellent centers to report outcomes, and we have extensive longitudinal cohorts. So there's extensive experience now in what patients are served best by surgical myectomy, and we understand the failure modes very well. So the importance of this slide is to make 2 points. One, as I mentioned earlier, the operation that we do today is not the operation done 20 or 30 years ago. What we perform today is an extended surgical myectomy, where the muscle is removed and we go lateral to the bases of the papillary muscle as we move deeper into the ventricle. And you can see this allows us to extend the myectomy further down for patients that have extension of their hypertrophy at the mid-ventricular level. In addition, we're able to address issues of the mitral valve, which we'll see in the upcoming slide. And here, this is an important point where we see mitral valve elongation in a fair number of patients that contribute to the SAM and left ventricular outflow tract obstruction. And here's an example in the right upper box where that extensive leaflet can be partially resected or imbricated to reduce the drag effect of the mitral valve that creates the SAM and left ventricular obstruction. So I believe the surgical myectomy remains the gold standard. The results are very predictable and titratable, and there's durable and persistent relief of symptoms in LV obstruction. And it's safe regarding and reproducible experience centers. So now we're seeing a mortality less than 1% and truthfully less than 0.5% in experience centers. The prevalence of acquired VSD is less than 0.4% at experience centers. Stroke is less than 1%. The need for a permanent pacemaker in patients with no underlying conduction abnormalities is now less than 5%, closer to 2 to 3%. And the need for late reoperation for recurrent obstruction is less than 2 to 3%. And that's reduced because of the use of extended myectomy to reduce mid-cavitary obstruction. And the need for mitral valve replacement for functional MR and not primary mitral valve pathology should be less than 2% at experienced centers. And this just highlights the effect, as the previous speakers have mentioned, a center effect on outcomes. With relatively modest experience of greater than 10 surgical myectomy procedures a year in the context of a heart team program, the results are excellent, with mortality less than 1%, VSD rates less than 0.4%, permanent pacemaker less than 5%, and the need for mitral valve replacement less than 6%. When you look at survival following surgical myectomies, late survival is excellent, with 1, 5, and 10-year survival reported at 98, 96, and 83%. And survival following myectomy reaches that of aged and sex-matched general population. And importantly, it is superior to non-operated obstructive cardiomyopathy for patients not receiving surgical myectomy. And it also has been demonstrated to reduce sudden death following operation. And these, again, a longstanding series cohorts from the Mayo Clinic demonstrating that the results are equally well when you adjust for baseline differences. The results are equally well for male and female patients. And importantly, there's near complete LV gradient reduction. So in approximately, we see a gradient of 60 to 80 millimeters per mercury, and we reduce that consistently to a gradient less than 10 millimeters per mercury. The gradient reduction is sustained at long-term follow-up, and there's improvement from a class 3 symptom to class 1 or class 2 in 80 to 90% of patients. It's a significant improvement in symptom burden. And unlike catheter-based techniques, there's precise controlled resection, and it's not dependent on infarct variability or coronary anatomy. So in summary, surgical myectomy is a comprehensive repair. It treats septal hypertrophy, the mitral valve abnormalities, particularly the papillary muscle abnormalities, which are not appreciated well on current degrees of imaging. The other important aspect to remember that concomitant procedures are common with septal myectomy. We're doing some component of mitral valve repair in at least 20% of patients. Coronary obstruction from muscle bridging is present in about 15% of patients with primary hypertrophic cardiomyopathy, and coronary unroofing becomes an option. About 25% of patients presenting with hypertrophic cardiomyopathy have a history of atrial fibrillation, and we can address that with a maze ablation and left atrial appendage ligation to reduce late stroke risk and improve survival. So why myectomy indoors? It restores normal physiology. It reduces obstruction. It treats the entire LVOT apparatus. It delivers immediate, durable, and predictable results. It's supported by generational evidence. And as the last take-home message, through guidelines, invasive septal reduction therapies, when performed by experienced hypertrophic cardiomyopathy teams at dedicated centers, can provide safe and effective symptomatic relief. Thank you.
Thank you very much, Dr. Pagani, for a great insight to the surgical myomectomy. And I'm joined again by Jafar, Omar, and Ignacio. And we will next move to a couple of questions from the audience. But first, Dr. Pagani, on your talk on surgical myomectomy, I love the fact that you brought up it's just not the septum, but is not only the leaflet, the subvalvular apparatus, and maybe perhaps the two steps to what Ignacio and Jafar, in Ignacio's case of highlighting is not just the septum, but also the leaflet as well. The two-step procedure might be crucial for these complex patients if they are not surgical candidates, of course. But to your point of surgical myomectomy, do we in the community have to refer to somebody specific for the surgical myomectomy, or is it the training of these surgeons? Are they equipped for surgical myomectomy for these complex patients?
Yeah, I think when you're evaluating patients for treatment for hypertrophic cardiomyopathy, it's best done in the context of an advanced heart team, where they have both options for alcohol septal ablation, for SESAME, and then for surgical options. In those types of centers, generally the experience on the surgical side is excellent, and also on the cardiology side to offer the different treatment options. And so I think that's the decision should be done best in a heart team sort of atmosphere.
Thank you.
If I can jump in there and echo that, may I? What a really interesting sort of patient pathway came out of such a heart team discussion. So sitting with my surgeon and the patient, and we thought for this particular patient who was a surgical candidate, and we were all recommending surgery, although they could have had SESAME, the patient actually asked, can I have SESAME and then surgery down the road if needed? And my surgeon said, absolutely. There's nothing to stop surgery after SESAME. It's not like you're creating a septal infarct, with alcohol septal ablation. Also with alcohol septal ablation, you take out the right bundle, and then with surgery, take out the left. So that kind of sequential approach is not favorable. Whereas with SESAME, I'm already making one of the cuts, and my surgeon then just has to go on and complete the second cut if needed, and then do anything with the mitral valve. So that was an interesting patient algorithm that came out of our heart team discussion.
No, that is great. And another question from the audience, Dr. Pagani, how many centers of excellence for surgical myomectomy are there at the present? And do you anticipate or observe a drop in surgical volume given the rise of these medical therapy and transcatheter options? Perhaps to Dr. Pagani and Jafar.
Thank you. Yes, I don't know the exact number of advanced centers, but they're available in almost every state in the United States. With regard to the impact of mavacamten and myosin inhibitors on volume of, yes, it has had a significant impact on volume, particularly in the older, the older population. Younger population tends not to want to take medical therapy for an undetermined duration. So a one and done type of approach seems more appealing for younger patients.
And Ignacio, how is it in Europe, given this new transcatheter option and surgical myomectomy in Europe? Do you see an increase in these transcatheter procedures?
Yeah, so there was a constant decrease in the number of alcohol septal ablations, especially since the arrival of myosin inhibitors. But as our colleague just highlighted, the younger patients do not want to take drugs for such a long time, especially new drugs. And on the other hand, there are not so many centers of excellence that doing the surgical myomectomy. So the number at this moment is rising. Of course, I think they are waiting for us to have a complete learning curve. But I envision that it will probably increase because I have the impression that this transcatheter strategy is simpler than and less operator dependent than a good surgery for myomectomy. I think the 3D printing and simulations are also very important to anticipate which patients need this and which would be the results both for surgery and for transcatheter alternatives.
Thank you. And Ignacio, another question to you from the audience. Have you had a case when in hindsight that SESAME was the wrong choice? And what screening rule do you change your program because of a case of such nature?
Yeah, there was one thing that Omar mentioned, and is how to estimate the width of the septum. And for me, that's key because there has been some septal defects secondary to SESAME. And I think that's because, okay, let's go a little bit deeper on the septum. If it's a hypertrophic cardiomyopathy, there is a very weak septum, so no risk. But that can progress if we are beyond 8 millimeters of depth. And this has actually happened. So first, a good estimation, good acquisition of the CT is key to understand how deep is the septum, how wide, and also do not condition the depth to that width. I would stay, in my limited experience, within these 7 to 8 millimeters of depth.
And Omar, any comments on that? And additional question to Omar as well. One of the questions from the audience is in patients with prior septal reduction, alcohol septal ablation, what are the extra planning steps that help you decide if SESAME is still feasible and safe?
Yeah, so on Ignacio's comment, I completely agree. I would say the number one thing I double check is the septal thickness, because although the operators look at imaging, I don't consider them imagers. So there's often a discrepancy. So I want to make sure everyone is on the same page when they're discussing what is the depth that's actually present. Because as I showed in my slides, you can get fooled, especially on the RV side of the septum, right? Some of that is trabeculation, so it's not a solid muscle. So if you get close to that area, you can cause a VSD if you get overconfident. So that's something to be very careful about. On the second one, I would say one thing that we have not solved on imaging is to really predict the integrity or stiffness of tissue, right? It's pretty unpredictable, I found. I don't know if others who have actually put in the wires have comments, but I haven't found a great imaging correlate of stiffness. I mean, I guess for the septal ablation post patients, you could consider getting an MRI to see if there's fibrosis there or not. That's the only possible thing I can think of. But otherwise, I think these various types of, I mean, we've had ones where the wire goes in like butter, and others where it's very, very stiff in the myocardium for some reason. And I don't have a great sense of how to differentiate the two.
Perhaps Dr. Pagani, any thoughts on that, the tissue integrity when you do this surgical myomectomy? Any insights that you could help us understand?
No, it's actually quite variable, and it really we typically get an MRI, so we have an understanding of the degree of fibrosis. But some septums are very fibrotic and difficult to excise, and some it's very soft muscle. So it really it's variable from patient to patient.
What are your thoughts, Jafar?
You know, I think one thing that we know causes problems, or two things, is previous AVR. You get a lot of fibrosis right at the anterobasal portion where you want to enter the wire. That can make things a little bit more challenging just getting into the muscle. And the second is a prior alcohol septal ablation usually makes guide wire navigation a little bit more challenging. Some of the very, very fibrosed patients with lots of fibrosis in the basal septum, navigation can be challenging, but you know, none of these things are deal breakers. You know, you can do the procedure in all of them. You know, you just do good catheter skills with good backup support, penetrative wires, and good microcatheter support, and you can get SESAME done in most patients.
Great. And a question as well, you know, for a general cardiologist in clinic, what are the simple signs or prompts that we should do to prompt a referral to you, Jafar, to a SESAME well-equipped, you know, high volume, capable center, besides good medical therapy? What should prompt us for that referral?
So we look at our patients in a HOCM center, which I think is the heart team model that any center should strive for, and most centers of excellence certainly have. So where we have an imager, a HOCM doctor, heart failure specialist, an interventionalist, and a surgeon, and then we have links to our electrophysiologist colleagues as well, with genetic screening as well. So I think a center like that, you know, for a general cardiologist, if you have a patient with HOCM, you know, they should be seen at a HOCM center. They can optimize their medications, their investigations, anything else. Many of these patients have rhythm problems, etc., that need to be taken care of. And then when they're at a stage to warrant septal reduction therapy, that's when the question comes in. Surgery with additional things like, you know, where the PAPs are, what the mitral valve looks like, or a transcatheter approach. In our center, we've more or less stopped doing alcohol septal ablation. So the transcatheter approach would just be SESAME.
And if a patient is very symptomatic, but really borderline between too high risk of a surgery and not really ideal for SESAME, how do you frame that discussion with the patient and their family?
So if they're a candidate for septal reduction therapy, you know, gradients of over 50 and symptomatic, typically, then we have the discussion to say, look, you know, this will benefit your symptoms and potentially longevity of life, and we need something. If they're high risk for surgery, I discuss SESAME with them. It's rare I mean, the only time when you say the anatomy is not favorable is if the septal muscle is thin. That's usually not the case for these HOCM patients. It's, you know, and as Omar said, we can treat thin septum, we just don't get a deep enough cut, so the effectiveness isn't great. You wanna kind of dive into a decent depth of muscle to get a good splay. So the conversation is reasonably goes along the lines of, this is a novel therapy. We don't have long-term outcomes in a large number of patients. The first procedure was done in January 21. The outcomes are these, which I quote the registry results. I also share our personal results in the hospital, which have been very good. We've had 0 mortalities, and then they make an informed decision from there.
Perfect. Thank you. And last question before we close, Ignacio. And I'll ask Jafar to say what's the vision for SESAME. But Ignacio, for fellows involved in SESAME or who wants to be involved in SESAME, the training, what are the top 3 things that you would want them to do and how they should go about being exposed to this technology?
So the first thing we do, and I do it myself, not only for the fellows, is we have a lot of TAVI patients. We do a lot of CT analysis for TAVI patients, and often they have hypertrophy. So let's just do the planning on these CTs, even if these are not cases for SESAME, because the analysis is the key. So the training like that in the analysis is key. Then, and maybe Jafar won't like it, I think it's very useful to be exposed to CTO procedures as well, because you learn how to handle this kind of wires and microcatheters, and that is useful for all the electrosurgical techniques, including SESAME. So Jafar, you are invited to come for some CTOs to our center whenever you want. And then third, of course, to get exposed to these kind of cases in the centers they are training, or even in other centers, follow these webinars. There are a lot of tips and tricks that are useful, and we are all learning together at this time. So get exposed to cases.
Oh, I would love to be in Spain and learn more from you as well. The question as well to Omar, how about imaging? You showed how the key essentials, I mean, so important, the pre-procedural and intraprocedural, how Jafar is dependent on you. And so what do you think for fellows? I love the, the statement in the paper that's coming out in JACE. I think all imagers should read it and be exposed to this so that they are equipped. What do you think that fellows or imagers should do or learn besides reading papers to be exposed to this technology?
So for imaging trainees, I mean, I think the key is your baseline training in structural heart disease imaging, right? All of the same concepts permeate through any device, right? You need to know what are the key anatomical areas to image, what are the tools that you're going to use to image them, which I mentioned, 2D, 3D, TE, TTE, sometimes ICE and others. NPR is a very key one for all of these. And then you need to be familiar with the equipment that's used by the interventional team, right? So that you know enough about it that you can follow every single step and every piece of equipment that's being used. For example, one thing we didn't mention, but sometimes whatever they're using as the microcatheter for the wire, we can't see it that well, right? So we have to tell them that we can't see it well, so they may need to switch it to something else. So tips like that. So the key is the baseline structural heart disease imaging training, and then, as you know, it's a rinse and repeat, right? Every new device, you follow the same process. So although this is an exciting procedure, it follows the same process as all previous ones. And I had never done one until I did one with Jafar, but with the excellent training we received from Becky, right? It was not difficult to apply the same principles and learn it again.
Well said. And thank you for putting the paper out. So I'm certainly looking forward to that. And before I close, Jafar, any last words as to your vision for this technology and how it's going to be looked at in the future and the spread of it?
Yeah, I mean, Dr. Pagani hit the nail on the head. This is also a complex procedure done at expert centers. It's not very democratizable in its current form. And And so I think the future of this, although it's in expert hands, it's very precise with excellent results. If we want to spread it, the future for this has to be a dedicated device for SESAME, because I think we've proved the concept. A myotomy through catheters works and helps patients. So if it can be done safely and reproducibly with dedicated devices, then it really will spread.
Well said, Jafar. I can't wait for it to be democratized so that the access to patients, especially for this TMVR, so many screen failures that we have in our center as well, and the limited options that they have because they're not surgical candidates. To Dr. Pagani's point, we would love to do it, and we come from a good surgical center too, led by Vinny. So truly, I can't wait for that day to come. And that this is such a great discussion. I learned so much. I hope all of you in the audience too, as we come to the end of the second episode of Nail It with Nadira, the Radcliffe edition on SESAME and surgical myomectomy. I would like to personally thank Jafar, Omar, Ignacio, and Dr. Pagani for really a very practical, insightful discussion, for taking time out of a busy schedule to join me, and all the questions from the audiences. Thank you so much. And the full recording for today's webinar will be available on Transcatheter Academy. You can also watch the first episode, the one on 3D eyes in tricuspid replacement technology. So please do share with your colleagues, your structural heart colleagues, your fellows, imaging and surgical colleagues. This is ongoing. It's my second episode, and I truly appreciate the support. And we look forward to the next episode. Keep a lookout for it, and we continue with really the whole aim and goal of this series, the case-driven imaging platform, and really concentrate on real-world decisions that really help us in our complex structural interventionists. My name is Nadira Hamid, and it's been a pleasure to host you on this second episode of Nail It with Nadira, the Radcliffe edition. Thank you for joining us today, and I certainly look forward to seeing you in my third episode. Thank you very much.